a very good evening and a warm welcome to the ISA online PG classes. These PG classes have been held regularly since July of 2021, where faculty of repute from all over the country spare their valuable time and effort for the benefit of not just the students, but many faculty alike who wish to see these classes. And these have been very useful for a lot of people. Today is a special day. We have a master class and a master class by a master. We have Dr. Naveen Malhotra, sir, who will be speaking on a topic of interest. I know it is a topic of his interest, role of retromolar intubation and submento-tracheal intubation in panfacial trauma, a very important topic. So may I request Dr. Naveen Malhotra, sir, to please speak a few words and introduce the class as the president of ISA National.
Thank you, Dr. Nishant. But today I am in a capacity of teacher, and I like to share the experience of doing this technique since 1999. So probably it was one of the first publications from our country on this particular topic, both submento-tracheal intubation and retromolar intubation. And I'll like to share my experiences. But as of now, I leave up to Dr. Rajiv Gupta, Honorary Secretary, to do the honors.
Thank you, Dr. Naveen. I welcome all to this ISA National Masterclass on retromolar intubation and submento-tracheal intubation in panfacial trauma. As we know that panfacial trauma, there are three alternatives what we can do to protect the airway or for the surgery. Maybe it is a retromolar intubation or submento-tracheal intubation or tracheostomy. So out of these, we have to select one. So how to select and how to take into account that which strategy is better for the patient. So when we say retromolar, so it's just like a normal intubation where we put the tube behind molar in the space, retromolar space, and we can start the surgery. So this is the simplest of all. Another one is this submento-tracheal, where normal intubation with the proximal end of the tube is taken out of through the median or paramedian approach. And third one is tracheostomy. So if we see that the patient has to go for ventilation for a longer time, then we prefer tracheostomy. Otherwise, we go for either of two. So Dr. Naveen would be talking on this important topic today. So I hand over the mic to Dr. Nishant to proceed for the further proceedings.
Right, sir. Thank you so much. And before we proceed, sir, we have our treasurer, Dr. Sunil Sethi, sir, also with us. So maybe request him to say a few words. Please unmute yourself, sir.
Am I audible now?
Correct, sir. Yes.
Good evening, Dr. Nishant. Thank you very much for inviting me. When I saw the speakers for today, then I thought the pioneers of the lecture and the technique, when they are presenting, although I have listened to this topic, but this is a very useful procedure, I must tell. Those tracheostomy is different, but retromolar and submental intubation. When I came to Karnal a few years back, then people said, sir, we have panfacial trauma. Then I remembered Dr. Naveen, and then I read the topic once again, and I did it. And the surgeons were so happy that, sir, you are doing the same technique, same procedure, and we are so happy with the results. And literally, this is a beneficial and a very useful technique. Every anesthesiologist should learn it. And it's a simple procedure, but needs some guts to put a knife. And sometimes you have complications also. I had one complication that the patient had some cyst formation after that. Some cyst was injured in the initial procedures. Only once. So it is not very simple. You must know the anatomy of the mouth of floor so that you can give the incision and avoid complications. Being simple, but you should know the technique also. I must congratulate Dr. Naveen for publishing the first article, and it will be lovely to Naveen. Thank you very much.
Right, sir. These are
Thank you, sir.
techniques, and yes, sir. So, sir, before we start any class, we seek the blessings of Mata Saraswati, and we should all join today also to seek the blessings of Ma Saraswati by playing the Saraswati Vandana. Have amongst us another very important academician and a distinguished academician, Dr. Indrani Hemant Kumar ma'am, who's also the governing council member of the ISA National. May I request ma'am to take over the proceedings from here on?
Thank you so much, Dr. Nishant. And I have this wonderful opportunity to introduce none other than Dr. Naveen Malhotra. Well, who doesn't know him? It's a joke if I have to actually introduce Dr. Naveen Malhotra. Still, having given this opportunity, I'm not going to let go of this opportunity. So, Dr. Naveen Malhotra, as you all know, is the current reigning president of both the twin societies, the biggest societies in anesthesia in the country, Indian Society of Anesthesia as well as Research Society of Anesthesia. He is also the president-elect of ISSP, something which is so close to his heart and that which he practices for his day-to-day living. And apart from that, we all know that he he has presented many orations, and he has won many awards and rewards. He's also the honorary secretary of SARC AA, and as a secretary, he was a transformational secretary basically. At the time when he worked as a secretary, I think he must have breathed every minute for ISA. And as a president, he is reformative and progressive. And today he's here to talk about a topic which is rarely discussed and something which is more, for all of us, it is something which is theory and less practical. And this is also a topic where you need skill, because we as anesthesiologists, we have also done, I mean, we didn't do it, but we let the surgeons do the submental intubation, or no, sorry, submental intubation. We have asked the surgeons to do it. But here we have our anesthetist, he doubles up as a surgeon to perform this both retromolar as well as submental intubation, and he's here to teach us how to do it. Over to you, sir. We're looking forward to hear lecture.
Thank you, madam, for those kind words. And these two techniques, I'm very sure by the end of my talk, you will find it very comfortable to do them. The retromolar intubation and the submento-tracheal intubation. I can say with conviction that you will find it easy because based on my experience of around 28 years. We all understand that this is the standard route of intubation, the orotracheal intubation. But if we have to do intraoperative maxillomandibular fixation, then orotracheal intubation becomes impractical. Earlier, it used to be done by wires, and now it is done by elastic bands, high tensile elastic bands. Now, for any surgical procedure involving face, this maxillomandibular fixation and proper alignment of maxilla and mandible is the key. Then only the plates and screws they are put. If this maxillomandibular fixation like this is not done, then the results can lead on to facial asymmetry. So you have to understand that this is the key step before you begin to operate and restore the facial contour. Now, the other route, if you are not able to do oral intubation, next is very good. We can do a nasotracheal intubation. Absolutely no harm. We have been doing it for years and years together. But suppose a patient has got a Leaford 3 fracture, fracture of nasal septum, where nose has also to be operated and orbit has also to be operated. There's fracture of base of skull. So then nasotracheal intubation is not possible. Tracheostomy used to be the alternative. In such cases, perioperative tracheostomy, but we all understand that it is associated with immediate, early, late, delayed complications. So to avoid perioperative tracheostomy, retromolar intubation is a simple, non-invasive alternative to both tracheostomy and submentotracheal intubation for securing the airway perioperatively. And this was our original research article published way back 21 years ago in Indian Journal of Anesthesia. Now, what is this retromolar intubation? Retromolar intubation and retromolar scope guided intubation, Bonfils retromolar scope guided intubation are totally different things. So here what we are doing is we are doing an orotracheal intubation with a flexometallic tube, which is then digitally repositioned in the retromolar region. That means the space behind the last erupted molar tooth. And then it is stabilized in position by fixing it with the first or second tooth by a dental wire. So we published this in Anesthesia in 2006. Now let's see a video of retromolar intubation, which will make things So you do a normal intubation of a flexometallic tube and then digitally reposition it behind the last erupted molar or premolar tooth. The last erupted tooth. So you can see the tube is now positioned in the retromolar region. The tube will take a curve behind the erupted teeth, and then you fix it in position with a dental wire in a figure of 8 manner. So in this way, you fix it up in a figure of 8 manner. Don't do it too jealously. And if you can see, the number here is 23. Normally, if at the angle of mouth, it is in orotracheal intubation, it is 21. It will be 2 centimeter more because the tube is going to take a curve. And then intraoperatively, the maxillomandibular fixation is done. The tube is lying just behind. And if you can see this patient, there is a fracture of maxilla also, there is a fracture of nose also. The tube is lying just before. So tube is just lying like away from the field, and they are operating on the nose also. They have finished the surgery on the mandible, and the tube is just lying silently. At the end of the procedure, you open up the elastic bands, remove the figure of 8 fixation, and convert the retromolar intubation to orotracheal intubation and extubate and as per the standard institutional protocols. The elastic bands are not applied usually by the facial surgeon in the first day. They will reapply it because now the plates have been fixed. So at the end of the surgery, there is a nasal packing is there, and nasal packing is there, and if maxillomandibular fixation is done, then if there's some bleed, some ooze, or some edema, it will be difficult. So surgeons also usually reapply the elastic bands next day when hemostasis is sure it's fine and airway edema is resolved. Now, for a successful retromolar intubation, you need to have a adequate retromolar space. And that can be done by putting your index finger in the retromolar region and ask the patient to close the mouth. I have measured the outer diameter of my index finger, and I know if there is no compression on this finger, a tube of 7.5 flexometallic tube can easily grow through that. If there is no compression on your finger, that means space is adequate. Further, you can increase the success rate by selecting a one size smaller. Like if you're planning to intubate orotracheal intubation with 8 mm tube, choose a 7.5. If it is a female, you're planning to choose 7.5, choose a 7, which will have a lesser corresponding outer diameter, and the success rate will increase. So these are the pictures of different patients undergoing retromolar intubation. In past, osteotomy used to be done to increase the retromolar space, but it is not preferred. That involved extraction of the last molar tooth and some destruction of the bone. So osteotomy renders this technique impractical, and it is beyond the scope of anesthesiologist also. And the bone which is being removed may be useful for fracture fixation devices. So nowadays, osteotomy is not at all indicated. The advantage of retromolar intubation is that if it can be done, it avoids the need of any surgical technique, whether it is tracheostomy or submento-tracheal intubation. Now, there are certain disadvantages also. The tracheal tube can interfere with the main surgical field. Too jealous fixation of tube with that figure of 8 dental wire can damage the PVC part of the tube. So don't do overzealous fixation, and it can interfere with positioning and application of dental fixation devices. But these are very minor things which you can plan accordingly if when you're doing the surgery to put the tube on the right side or the left side. You can put it on the opposite side where the surgery is being done. But in 5% patients who are bulky, who are very obese, dental occlusion is not possible. You have put the tube, but dental occlusion is not possible. And that means there is inadequate retromolar space. And putting that pressure is leading on to deformity of the rings of the flexometallic tube. Then submento-tracheal intubation is indicated. Now, what is the submento-tracheal intubation? We published this for the first time in IJA in 2002. It has got a midline approach and it has got a lateral approach. Lateral approach is easiest and most commonly done. Herein also, you do an orotracheal intubation using a standard general anesthesia technique with a flexometallic reinforced tracheal tube. Now let's see a video. You require certain sets of equipments, a 15-number blade, equipments for cleaning and draping, a curved artery forceps, and equipments for suturing. A flexometallic tube using standard general anesthesia technique has been done, and you clean the submental region, the area below the mentum and the lateral aspect. Before starting the procedure, please switch on 100% oxygen and monitor the vitals, because there will be some period of disconnection of the tube when you're taking it out. Now, this is the important thing. You give just stop it here. 1.5 centimeter incision parallel to the inferior border of mandible. And this incision is 1.5 centimeter lateral to the mentum. So this is the mentum, its lateral edge. So 1 to 1.5 centimeter incision starting from the lateral edge of the mentum, parallel and inferior to the mandible. It is an absolutely no man's land, don't worry. Now, if you don't want to injure any ducts and cause cyst, just remain just along the medial border of the mandible. Just do the dissection, keeping so I'm putting my counter here. So I'm going through skin, subcutaneous tissue, mylohyoid muscle, and opening in the floor of mouth under vision. If you open up in the floor of mouth under vision, you will not damage any submandibular gland, sublingual duct, or any gland. Absolutely open up on the floor of mouth under vision. First, take out the curved artery forceps. With the curved artery forceps, take out the pilot balloon. And then reintroduce the curved artery forceps. And remove the tracheal tube connector. At this point, just stabilize the tube with other hand so that there is no accidental extubation. And now this tube has been extracted out through the submental tunnel, which you created. You check the air entry. It is equal, and fix the tube just like we fix any intercostal chest tube drainage. So now this is our submental tube in situ. Intraoperatively, the surgeons are doing maxillomandibular fixation and the tube is lying just away. So dental occlusion has been restored. So they are operating with over the mandibular and maxilla. And at the end, again, you got two options. You open the maxillomandibular fixation, do a thorough suctioning, and you can take out the tube through the submental tunnel, or you can convert it to the oral and then extubate. And then you apply interrupted sutures over with 1020 silk. There is a midline approach also where you remain straightway in the midline. The theoretical advantages are it causes less incidence of involvement of sublingual duct, but with our own experience, I can tell you lateral technique is most commonly used because it is technically very easy. You don't have to pull the tongue, and it is very, very convenient if you go from the side of the tongue along the mentum. Now we have used two tubes also. Earlier, the tracheal tube connector was not removable. Now with the PVC one, you can put a curved artery forceps, just glue is removed and the connector can be removed. But in the past, when we used to have a silicone tubes, the tracheal tube connector cannot be removed. So what we do is that we put one tube orotracheally, we create a submental tunnel, and then we introduce another tube from outside into the oral cavity. Let's see the video. So already an orotracheal intubation is done. We do dissection and introduce the curved artery forceps into the oral cavity, bring out another curved artery forceps from oral to submental tunnel, and then we bring the tube from submental route into the oral route. So now you can see that there are two tubes, one in the oral cavity and one which has been brought from outside to inside. And then under direct laryngoscopy, with the help of curved artery forceps, you will remove the orotracheal tube and introduce the tube which has been moved from outside to inside across the submental tunnel into the oral cavity. After doing thorough oral suction, and then you can suture this tube in situ. The advantage of two tube technique is that there is less risk of compromising the patient airway, and the disadvantage is that while drawing in tube from outside, if we catch hold of the cuff, then tracheal tube cuff can get damaged. I talked on midline approach, lateral approach. There is some mandibular approach also, where you are giving the incision 1 inch below and ½ inch anterior to the angle of mandible. That means you are far more lateral and you're opening in the mouth medial to the second molar tooth. The advantages are that it avoids trauma to the submaxillary duct and sublingual gland. But as I told you, if we do the dissection under vision, such an incidence is very, very less. Now, a word about retrograde submentotracheal intubation. When mouth opening is limited, what you do is you do puncture of the cricothyroid membrane, and from that, a soft J-tip ureteric guide wire is advanced retrograde into the oral cavity. Then you make a submental tunnel under local anesthesia. Do blunt dissection through skin, subcutaneous tissue, myeloid muscle into the oral cavity, and draw this guide wire outside. And then you put a tracheal tube exchanger over this guide wire Now this tracheal tube exchanger is going from submental tunnel into the trachea, and then you advance flexometallic tube over that. Just like we do retromolar retrograde intubation, this is a retrograde submentotracheal intubation. Now this was which I was talking about, silicone PVC tubes whose connector was not removable. While pulling out the pilot balloon in one of the patient, the inflation tubing got disconnected from the pilot balloon. So for that, we devised a technique known as sleeve device by Malhotra and Malhotra, myself and Dr. S.K. Malhotra, and published in Anesthesia Analgesia in 2002. Wherein what we took was, we took a 10 mm PVC tracheal tube and 10 mm, 10 centimeter length, and cut it on one side this way. So this is a 10 mm tube, cut it on from one side. So we put this inflation tubings and the pilot balloon inside this sleeve and applied pressure on this sleeve so that there was no direct pressure on the sleeve, but on the sleeve device. There was no pressure, direct pressure on the pilot balloon and inflation tubing, but on the sleeve device. We have used tracheal tube exchanger also. This was published in Anesthesia 2005. If there is damage of the submentotracheal tube and you have to change the tube, you can easily put tracheal tube exchanger, remove the tube which you want to change, and then thread a fresh tube over the tracheal tube exchanger. You can easily ventilate also in between. You are removing the tube which you want to change, and then you can press a thread a fresh tube over it. Now, if you want to do suction through this submentotracheal tube, the curve is easily negotiated. You can put a tracheal tube exchanger. Similarly, you can put a endotracheal suction where you can do suctioning as and when required. There is no concern about the steep angle or so. The standard institutional antibiotic cover for trauma patients, usually whatever institute protocol is there, that antibiotic cover is sufficient, and you ask to do 0.2% chlorhexidine mouthwashes every time they eat or drink, and at least 4 to 6 times a day to maintain oral hygiene. The antiseptic dressing over the stitch line is removed. Antiseptic dressing is applied and the stitches are removed on 6th or 8th post-op day, and scar is almost invisible after 2 months, and it is aesthetically pleasing because it is below the mentum, so it is not visible until unless neck is extended. For how long the submentotracheal tube can be left in situ? It has been left maximum for up to 3 days, and through that mechanical ventilation can be instituted, tracheal suction can be done, and nowadays we have got PVC tubes with low pressure, high volume cups, so there are absolutely no issues. But if ventilation is required for more than 3 days, then tracheostomy comes in. So advantage of submentotracheal intubation are it provides a secure airway, unobstructed intraoral surgical field, allows intraoperative intermaxillary fixation, and avoids complications of tracheostomy. And these are the different indications in craniofacial-medullary trauma, leaf fracture, multiple fractures of the maxilla, mandible, and nose. So these are all indications of retromolar and submentotracheal intubation. Also, in tumors of base of skull, which are the clival chordoma, where this will be published in Journal of Neurosurgical Anesthesia in 2004, where iatrogenic leaflet 1 osteotomy is done from the transoral approach for the base of skull of tumor. So if you can see that here the maxilla and mandibular are opposed to each other, so oral is not possible. Nasal intubation does it comes into the field. So this is the intraoperative X-ray where the submentotracheal tube is lying in patients with clival chordoma. The other indications have been facial reconstructive surgery, tumors of maxilla, and patient reluctance to have a tracheostomy. Contraindications for these techniques are long-term airway support, more than 3 days, gunshot injuries, tumor ablation in the facial-maxillary region. The disadvantages are that it is an invasive technique because retromolar intubation is totally non-invasive technique. If antibiotic cover and oral hygiene is not maintained, superficial wound infection can occur. Don't worry about that. They will definitely heal with secondary healing. No resuturing is required. You can simply give antibiotics and maintain the oral hygiene with chlorhexidine mouthwashes. Hemorrhage, in my initial cases, we deal with aortic dissections and punctures by surgeons. But when we do incision and if there is 10-15 ml of blood loss, we get too much worried. So in the initial days when I used to do, there was some bleeding. So I told surgeon, what should do? But why are you worried? Take artery forceps and cauterize it. So I did that and simple. So, but that things can occur. Trauma to ducts, as I can tell you, is avoided if you are parallel and inferior to the medial border of mandible. It's no man's land, and open up in the mouth, open up on the floor of mouth under vision. Now, practically speaking, from the year 2001 to 2004, majority of the patients whom we did were panfacial trauma, facial reconstructive surgery, the maxillary advancement and setback, transmaxillary excision of clivus chordoma, failed nasotracheal intubation, and everything was submentotracheal intubation. And the majority of the patients were young because of road trachea accident. Majority were males, and submental fixation of tube was 2 centimeters more than oral. Just like retromolar, it also takes a curve, and the submental exit point fixation is 2 centimeters than the oral. And total duration took 8 to 10 minutes. And blood loss was less than 10 ml in all the patients except one, which I was discussing. It was 20 ml. And mean duration of surgery was 5 hours. Out of 54, 52 were extubated on table. 2 patients were ventilated for 6 hours and extubated in recovery room. Route of extubation was 50 through submental tunnel majority, and none of the patients required post-op ventilatory support. And adverse events, disconnection of inflation tubing from pilot balloon, so leading on to repeating the procedures, leading on to invention of sleeve device, which got published in Anesthesia Analgesia, extension of skin incision in the initial time when the incision was increased, so there was bleeding, which was managed with cautery and sutures. There were 2 subcutaneous infections also, so which required drainage of the collection and antibiotic cover, but there were no delayed complications, there were no failures. From 2004 onwards, total number of patients done was under 15, and 107 we could avoid submentotracheal intubation and tracheostomy by doing retromolar intubation. These patients were again, majority were young and males, and fixation of tube was 2 centimeters more than oral, and it took only 2 minutes to perform the procedure as compared to 8 minutes for submentotracheal intubation. There's no blood loss in retromolar intubation, and route of extubation was in all the patients of retromolar, it was converted to oral, whereas submental intubation, it was through submental tunnel, and there were no adverse events with retromolar intubation. Now, as I come to close of my class, I'd like to show you the videos once again. But since I have talked about retromolar intubation, it is imperative on me to talk about Bonfils retromolar scope guided intubation also, so that there is no confusion. Bonfils retromolar scope guided intubation is done when mouth opening is limited, and herein you use this curved Bonfils retromolar scope on which the tube, its tip is just beyond the tip of the tube, and there is a connector where you can fix it, and if you loosen it up, you can introduce the tube into the trachea. So it is introduced through the lateral side, and then you go into the across the vocal cords, loosen the screw, and introduce the tube into the trachea, and take out the scope. So this is a totally different thing, the retromolar scope guided intubation. So a revision of the retromolar intubation. Where you have done of intubation with the flexometallic tube, which is digitally repositioned in the submental tunnel. And fixed with usually with the upper teeth in a figure of 8 manner with dental wire. You can do it with the lower one also. The oral exit point increases by 2 centimeters because the tube is going to take a curve. This should be done gently so that there is no damage to the PVC covering of the flexometallic tube. Figure of 8 manner. If there are arches, it is easy. Otherwise, you can use the space between the 2 teeth to hold the tube in situ. This is the path the tube follows. You can increase the success rate by choosing a one size smaller, which has a corresponding lesser outer diameter. And then intraoperatively maxillary mandibular fixation can be done, and the surgery over the nose, over the maxilla, over the mandible, everything can be done. So there is no need for perioperative tracheostomy. At the end of the surgery, you remove the elastic wires, convert the retromolar tube to an orotracheal tube, and after removing the figure of 8 dental wire, and extubate as per the standard regime. Submento-tracheal intubation, lateral approach. If this is not possible, retromolar intubation, you clean the parts, take a covered artery forceps, 15 centimeter blade, equipment for cleaning and draping and suturing, clean the parts, the submental region. You have done intubation with a flexometallic tube whose connector is removable. At the lateral edge of the mentum, you give 1.5 centimeter parallel and medial to the inferior border of mandible and do a blunt dissection with the curved artery forceps through skin, subcutaneous tissue, mylohyoid muscle, going as close as to the mandible. So lateral border of mentum, 1.5 to 2 centimeter incision in the 15 number blade, curved artery forceps, applying counter through your other finger, remaining as close as possible to the inner aspect of mandible, that is a no man's land, and open in the mouth and the floor of mouth under vision, avoiding any trauma to the ducts or glands. So this tube connector has already been disconnected, loosened, and first take out the pilot balloon and inflation tubing, then remove the tracheal tube connector and take out the tracheal tube. While doing it, please hold the tube with other hand so that whole tube does not comes out. And then attach the connector and suture it. Again, exit point is 2 centimeter more than the oral. Check air entry and fix with 1020 silk suture. Intraoperatively, the maxillomandibular fixation is done by the surgeons and the tube is lying just away and they can do all sort of surgeries. At the end of the surgery, the maxillomandibular fixation is removed, sutures are cut, and you can do thorough orotachial suctioning and extubation through submental tunnel and apply interrupted 1020 silk sutures. And this we do it ourselves. None of the thing is done by the surgeons. And as we discussed, that if the tracheal tube connector is not removed, then you can use a two tube technique wherein you draw another tube from outside to inside when the tubes were such where the tracheal tube connector could not be removed. Then do a direct laryngoscopy, remove the orotracheal tube and under vision introduce the submental tube into the trachea. If you want to use this was about sleeve device. If you want to use a tracheal tube exchanger, you can easily use it. If you want to change the tube, absolutely no issues. There is no concerns regarding the angle which the tracheal tube exchanger has to negotiate. It can be with a lubricated one. It is easily done. And in the same way, you can easily do tracheal tube suction. And as I was telling, these are totally different techniques. You can use it for facial trauma as well as transmaxillary excision of clavicle chordoma. But these two techniques are totally different and from retromolar scope guided intubation, which is a equipment guided intubation. If you have got retromolar scope, especially in patients with PM joint ankylosis, this retromolar scope guided intubation is frequently done. The tip of the scope is just inside the tip of the tube. There is a screw which can, if you fix it, and if you unlock it, the tube can be pushed inside. You negotiate it through the retromolar region into the seeing the epiglottis and into the across the vocal cords into the trachea. Loosen the screw and introduce the tube into the trachea. So to conclude, in selected group of patients, retromolar intubation is a simple, non-invasive alternative to submentotracheal intubation for securing airway perioperatively. When retromolar intubation cannot be done, submentotracheal intubation is a useful and relatively harmless alternative to tracheostomy for securing the airway perioperatively. Thank you for your patience. Thank you very much. You are muted,
Ma'am,
madam.
please mute yourself.
You are muted, madam.
Thank you so much for such a wonderful lecture as well as demonstration of submental intubation and retromolar intubation. We were so happy and so happy to see a young and handsome Dr. Naveen Malhotra in those videos. And through those videos, we could also appreciate the enormous amount of experience you have derived in doing these retromolar and submental intubation. Through these, in spite of us having so much of experience, we always had a surgeon doing it. I mean, it was never us doing the submental intubation, and you made it sound so easy for us, to do it. And we do not have many questions. And Atam Singh Hiru, I think, are you the same who worked who worked with me in KM Hospital?
Yes, ma'am.
Okay, Hiru. Okay. I think your question is answered already, right? Because he repeated the videos.
Yes,
Dr.
ma'am.
Hiru.
Yes,
Yeah,
ma'am.
he
You know,
repeated
for
the videos,
submetal
and I think your
intubation,
question is answered. How to disconnect the connector
Yeah,
of the
okay.
metallic, and if you cannot, you do the double tube technique. He said that.
See, but
And
I'll just like to clarify it again, Dr. Hero. In the earlier days, connector was not removable, but with the advent of PVC tube, it was fixed with a glue. So what we used to do is we used to put it in the lukewarm water beforehand, before starting the orotracheal intubation, and we used to put a curved artery forceps along its connector to loosen it up. So that was the first step, that you loosen it up and so that you can refix it again. So if you connector is not removable, the incision becomes very big. So it is nowadays absolutely no worries. Put it in liquid water and introduce the curved artery forceps along the connector. It can be easily detached.
yes. And we have Dr. Simrat who's saying, why not tracheostomy? Why go through all this?
Yeah, that is the thing which you have to remember. Perioperative tracheostomy has got numerous issues, and if you can do retromolar intubation, which you can do it in more than 95% of the patients, what is the need for an invasive technique? Well, I'm not talking about submentotracheal intubation. Retromolar intubation will avoid submentotracheal intubation and tracheostomy in 95% of the patients. So why to go for any invasive, whether it is less invasive submental intubation or more invasive tracheostomy?
So I don't think there are many. If there are any more questions, please
Yeah, but,
feel free to unmute and ask questions. But in the meanwhile, may I ask few questions, sir?
Most welcome, madam.
Sir, you have spoken about the central approach, 1.5 centimeter lateral to the mentum, and also the submandibular approach, right? Which do you think is safer and best with least complications?
Lateral approach, madam. Lateral
Lateral,
approach,
1.5 centimeter lateral.
yeah, you start from the mentum and go 1.5 centimeter lateral.
Huh.
So theoretical thing you should remember is please open in floor of mouth under vision. Once OT lights are there, you can see that when you're opening in the floor of mouth, there is no duct, no gland. If we go submandibular, lateral, more lateral, then in chances of trauma to submandibular gland can occur. Midline we have done, but it requires a lot of pulling of the tongue in from the center, and it is not very comfortable for us to do it. So lateral approach is technically very easy. Now with the question that whether surgeon do it or you do it, see that depends upon you because airway is your domain. I must place on record my deep sense of appreciation for my teachers who stood by me and said you do it. At some places, surgeons were very happy that I am doing it. At some places, surgeons wanted to do it. But on both instances, whether surgeons were cooperative or non-cooperative, my teacher stood by with me, whether it was PGI Chandigarh or at PGI Rohtak. So they stood by me, no, it is airway is anesthesiologist domain. Even it involves giving an incision of 1.5 centimeter, absolutely nothing doing it. Our boy will do it.
How nice, sir.
Sir,
So
good
one more
evening.
question I have got is, see, you have placed an armor tube,
Yes.
and out of your 54 cases, 52 cases got extubated because you can't leave an armor tube. But in 2 patients, you left the armor tube, is it? For
Ma'am,
post-op.
it was for 6 hours, but armor tubes now have got low pressure, high volume cuffs. The PVC,
Silicone.
in
It's not, but at that time it
the, at
was
that time, when we were
latex, right? At that time.
latex or silicone, it was high pressure, low volume. But with the advent of PVC tubes, which have got low volume, high volume, low pressure cuffs, so we could easily do with that. And those patients were also extubated within 6 hours of surgery.
Okay, 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 sir. So I leave the floor open to other
Yeah, yes, Dr.
questions.
Geeta, please go ahead.
Yes, sir. Good evening, ma'am. Sir, I want to say that we are also doing the submental intubation by the modified ultimate techniques, means midline approach,
Yes.
because we are saying our experience that in the midline we have the less bleeding, matlab less chances of the any blood vessels. When we do USG at the submental area, so in midline there is a minimum chance of the blood vessels. Number two, there is a less chance of the
Duct.
glands
Duct.
injury to the duct. And third, we also doing a thesis to compare the modified ultimate technique with the Saldinger technique using the serial dilator for which used for the tracheostomy tube. So one thesis is completed by our student. So we also find that when we do this with the serial dilator, there is a bleeding chance is minimum by doing this technique from the midline. So we experience this is better. So, for this we have to need the equipment of for the serial dilator. Is this? Yes, ma'am.
Dr. Geeta, I agree to you to an extent that theoretical advantages of midline are, yes, definitely less trauma to the duct and less bleeding. But to be honest, how much is the bleeding? Whether you go by the lateral approach, why are we anesthesiologists worried about 5 to 10 ml of bleeding? We are dealing with a facial-maxillary trauma patient who intraoperative will bleed 400, 500 ml. So, but I'm very happy that you're doing a research work on that. But hopefully the anesthesiologists are doing the dissection or the
Yes,
surgeons
sir.
are doing it.
No, sir. We are doing on within
Excellent. So
4 to. Yes,
whether
sir.
you do midline or you do lateral, I am
Uh,
very happy. Please, you follow the technique which you are most comfortable with, but please do it yourself. Great.
yes, sir. Our dental surgeon say, sir, madam, give me to chance. So we do. हमने कहा no sir, this is the our part, so we will do. So continuously we are doing. I think we have the 4-year experience in this continuum maxillofacial surgery by the submental intubations.
Great.
We also try double tube technique. But in this, sir, we experience only we do the one case. The tube, second tube which we insert through the submental region, it's very difficult to move the tube. Even that Megal's eye, where we this cap the forceps to introduce inside, but it's many time rupture the cuff. मतलब और ना ने भी किया था पर ये वाली प्रॉब्लम आई थी तो हमने फिर इसको डिस्कार्ड किया.
But then the whole purpose of your double tube technique is to not to puncture the cuff.
Cuff.
That
So
was the whole purpose.
बट सर हमने जो किया वो
नहीं,
we experienced that the
actually what we used to do it because the tube has to negotiate an angle, hold it from above the cuff so that you're not. But if you're putting a Megal's forceps at the cuff or below the cuff, then the tube gets damaged. The cuff will get damaged. Moreover, nowadays double technique is actually not required also because the connectors are easily removable.
yes sir. But we do for the just experience.
Okay, fine, fair enough.
Hmm.
Yes,
Thank
Dr.
you, sir.
Meenakshi Sundaram, sir.
So nice to have Dr. Meenakshi Sundaram sir
Right.
amongst us.
It is
Sir,
nice to
why
have.
don't we need your few words.
See, actually, as a speaker now, I want to profusely congratulate Dr. Naveen Malhotra because today I'm seeing a different Naveen Malhotra. See, as a speaker, instead of giving it in a lecture mode, he was in a educative mode. This is the first time I'm seeing, and now I want because as he's the ASA president, we can take it forward. This should be a model even for workshops. He need not have wasted the times in anatomy, physiology. See, once he has straight away, he has come to the demo mode straight from the first slide. And another one, he was just interact. He was very cool, and he has talked about his experience. So in Hindi, there is a kahavat na, karo pehle kaho piche. So he has done it early, and now he is explaining it very clearly. And the way in which he explained, it seems that he is thorough. So a teacher should be like that. So instead of giving a lecture, now I have seen a teacher in his lecture mode, in his delivery. It was very good. And somebody asked about, and I want to object. You are seeing a handsome young Naveen Malhotra. Now only I am seeing the handsome young Naveen Malhotra. At that time he was like a student. So now only he's seeing. And somebody asked about that tracheostomy. See, actually, tracheostomy should not be the first choice for the simple reason they cut a bit of cartilage. So at any point of time, it can go for stricture. So if at all you want to do that tracheostomy safe, you have to intubate first somehow. Then you have to do a needle tracheostomy. Meaning it is a dilated percutaneous dilatational tracheostomy, PDT you have to do. Then only you will not damage any cartilage. So surgical tracheostomy, definitely it is a problem. That too, when we are having so many ways of doing it. And he has very clearly said, airway securing is the anesthesiologist's domain. We should not say, we are not asking the ENT surgeon to intubate, even while translectomy or mastectomy, even though they are also very thorough. Securing the airway is not putting the tube in trachea. It has so many things, but it is a greatest experience today because very casually he has explained everything. That will give the courage for the students also. I think this modality, secretary is also here. So we can have all the workshops. They should not, we can even say they needed waste so much of a time in anatomy and physiology because I have seen in conferences when people have come with a little bit of learning only. So we have to top up. But again, they are talking everything. Trachea bifurcates, straight bifurcate, 25-degree bifurcate. They waste a lot of time. He has come for the thing. When somebody asks a question, we can elaborate on anatomy. So I profusely congratulate, and a nice thing I have attended to the lecture. Just I have seen. Usually secretary will drop a personal message for me. Just 6:30 I have seen. Immediately I have entered, and I have seen madam also. Thank you very much, sir. Keep it up.
Thank you, sir. Thank you very much. Dr. Tanveer,
Fantastic.
you raised your hand.
Yes, sir. Sir, it's always a pleasure to listen to you. And sir, just I wanted to add one thing. Is it always that we use armor tube only? Can't we use the simple tube?
Yes, I wanted to touch that. To be honest, people have used PVC tubes. There have been case reports published also. But in any of the technique which you are using, retromolar or submento-tracheal intubation, it is going to follow a curve. And
Okay.
if it kinks, so then whole effort will go waste. So my suggestion is please put a flexometallic armor tube.
Yeah, so
Don't. It has been used. I know, but if 90% of the times you are successful, but once it is, you imagine that you get skinked and you fix it to the suppose it's the retromolar intubation and the tube gets kinked and you have already fixed it. Surgery is going on. So why to be in that sort of soup?
yeah,
And
right. So
flexometallic tube
One
is not
Dr.
is
Gayatri has written,
yes, sir. Now the cost is also not very much. Earlier
no
it used to be there. Yeah.
it's a cheap alternative.
Yes, sir. Thank you, sir. Thank you.
one Dr. Gayatri has written, how is the postoperative ventilation as mouth is sutured? So I think you've already answered. We are not ventilating the patient.
See,
So we are extubating the patient. So the purpose is not to ventilate the patient.
Faciomegally surgeons themselves want to open the mouth because otherwise what will happen? Patient's nose is packed, mouth is sealed. What will he do? So they intentionally open up the elastic bands so that whatever blood or sputum is there, patient is able to everything he cannot swallow. So he has to spit it out also. So they will after the next day's round, they will reapply the sutures when patient is comfortable, fully conscious. So on that, they will before surgery, as soon as you have done the airway has been secured, before start of surgery, they will put the elastic bands, earlier the elastic wires, and before extubation, they will remove the elastic wires. In case of large thyroid, it may be helpful, sir, as tracheotomy is also difficult.
I don't think it's relevant to this topic.
No,
It's not
thyroid.
relevant.
These two techniques have got
Different.
very selective indications in patients with panfacial trauma, where orotracheal intubation is not possible because you are going to do a maxillary mandibular fixation, and nasotracheal intubation is contraindicated in those cases where nasal surgery is being done. Then, to avoid perioperative tracheostomy, you do either retromolar intubation or submento-tracheal intubation. Dr. Geeta, you wanted to say
Dr.
something more?
Tulsidas? Okay. I think his audio is on, but he is not asking any question.
Sir,
Anyone else who wants to ask any question?
what should we do if patient bites while extubation? What will he bite? In the submental region, the tube is lying here, so he cannot bite. And in retromolar intubation, you have converted the retromolar tube into an oral and then given reversal and then extubated. So there are absolutely no chances of tube getting, the patient can bite the tube. I'll repeat, in submentotracheal intubation, you are going to pull it like this. Mouth is open, do suctioning, laryngoscopy, everything is cleared, remove the tube from here. In retromolar, you remove the wire, convert it into oral, then give reversal and then extubate. Yes, Dr. Gayatri, please, if any other, you can clarify with me.
Sir, good evening, sir. One question, sir.
Yes, please.
So this is Dr. Zahid from Andhra Pradesh, sir.
Good evening.
Sir, any specific preoperative investigations we should order for the patient prior to the surgery, sir, before performing submental intubation, sir?
See, routinely, most of the things would have been done, but absolutely, if no specific investigation required, if you're doing retromolar, put a finger, your own finger, into the patient's retromolar space and ask him to close his mouth. If you feel no pressure on your finger, put a gloved finger. If there is no pressure on your gloved finger, that means space is adequate.
Sir, any ultrasound requirement, sir?
None, because we are lying just along the inferior border of mandible and opening in floor of mouth. So distances and all those things, or this is not required, to be honest.
Okay, sir. Thank you, sir.
Yes, Dr. Gayatri.
You're
Madam,
not audible, Gayatri.
if you're finding it difficult, you can
You
type
can
it out.
type it. Type it if you cannot say anything. In the meanwhile, Dr. Rajiv Gupta, do you want to say anything, sir?
Yeah, it was a wonderful talk and interactive also. He's tried to explain each and everything, how we should proceed with the procedure and what all are the preparations, how we should prepare ourselves for this. And yes, absolutely, anesthetist should be daring and he should be able to perform all these procedures by themselves, not asking surgeons. Yeah, they may be present there because they are also bothered about their patients. But the procedure should be done by ourselves. So I have done so many and never found any problem. But yes, surgeon was always around your head to see if something goes wrong or not. So that is one thing. And second thing, someone was asking about the intermaxillary fixation also. So in older days, they used to fix it with the wire. And nowadays, they are doing plating and also this
The band, rubber band.
maxillomandibular, fixation is only for proper occlusion, so that in a proper way they can fix the mandible and all. So nowadays they don't keep that wiring after the surgery.
True. Earlier, if there was any bleeding, then they'll have to cut the wire and all that.
We
All
used to
that
keep
is
the
all
wire cutter along with the
Cutter
backside
was
of the patient.
pasted. Dr. Rajiv, cutter was pasted with patient's shoulder.
Yeah.
Yes, I remember this. Yes. True,
So
true. And
in those
one more
times,
thing I
it used to
forgot
happen.
to tell, it was so nice to see the old dear Boyle's machine in one of your videos.
yes, these
Something
videos
which
were.
we all grew up with, It was so nice to see that. I think there aren't many questions, and well, we had an excellent interaction. It was a topic which is less theory and more practical. And thank you for all the pearls, Dr. Naveen Malhotra. It was a wonderful session. And yeah, anyone else wants to speak? Anyone wants to ask anything still more?
Yes, madam.
Dr. Saik.
I
Yeah, okay.
ask one question to sir.
Your voice is
Sir,
breaking, sir.
whether it is need to decrease. Okay. Now it is audible?
Yes.
Yes,
Audible?
Dr.
Hello?
Yogi.
Yes.
Hello?
Yes,
Yes.
audible.
Sir, yes. Sir, it is necessary to cut the tube in length after it is submandibular excision when we cut out the tube exist. Length का कोई decrease करना जरूरत है?
नहीं, there is no need to cut the
He's saying,
tube.
should we have to cut the tube in the air?
Yes.
नहीं, nothing, sir.
No need, sir.
Absolutely no need.
Okay. Or sir, if we try the orofacial fiber optic, this one is preferred than orofacial fiber optic than the TA in case of emergency trauma case?
Sir, if
Sir, this is for surgeon's comfort, sir.
Okay.
the bottom line you have to remember is that if you can do an orotracheal intubation and keep it in the oral route, fine. If if nose is not damaged, there is no CSF rhinorrhea, no epistaxis, no nasal bone fracture, they don't have to repair the orbital fractures. Do a nasotracheal intubation. When you cannot do an orotracheal intubation because of intraoperative maxillomandibular fixation, and when nasotracheal intubation is contraindicated, then to avoid tracheostomy,
we can go
retromolar intubation is done. If you cannot do retromolar intubation, then submento-tracheal intubation is done.
Okay, okay. Okay, sir. Okay,
Sir,
thank you.
Sir, I also want to one thing add.
Yes, Dr. Geeta, please.
Sir, one thing, we also use the dental bite block on the posterior side so that the oral cavity open, so that the space in the oral cavity is easily we can handle.
I think the surgeons also use that, ma'am. I think the surgeons also
No,
need it.
we are also using, we have the different color of this dental bite blocks.
Okay.
Fine.
Thank you, sir. Thank you.
Nice. So over to you, Dr. Nishant. It was a wonderful session, very interactive.
Yes, ma'am. And as Meenakshi sir has said, this was an educator's class. This was actually called the master class. I mean, it was a real master class. Sir has not written down what needs to be done. Sir has shown us what needs to be done, and I'm sure it will be viewed a lot in the different YouTube videos, and I'm sure it'll have a lot of views. So if Rajiv Gupta sir, if you permit, we can just close the class.
Yeah, I think we had sufficient discussion, and most of the people who have asked the questions, they have rightly answered. So I think we can close the class. Thank you very much, Dr. Naveen sir.
Thank you,
Dr.
Ji. Thank you very
Indrani
much.
and
Thank you.
Dr. Nishant for nicely conducting this very interesting webinar for the ISN National. Thank you so much. Good night and long live